So good day, everyone. Thank you very much for your kind invitation. It's a great pleasure for me to be here with you. These are my disclosures. So when we perform surgery, especially hip arthroplasty, our goal is to achieve biological fixation and use implants that mimic cancellous bone. The previous coatings that we used to have, they have limited depth and the increased stress shielding, whereas with the trabecular metal and trabeculars in general, we have higher porosity, better elastic modulus, and high friction for primary stability, which help us during our procedures. So it's quite a long journey. It starts almost 40 years ago, and we started with the first generation grid blasted titanium cups and plasma spray titanium, and then we moved towards a second generation with sintered titanium beads and wire meshed. More recently, we start using porous titanium coatings, trabecular tantalum, and then we arrive today with using 3D printed titanium implants. So we're going to have a look at the mechanical properties of these implants, especially talking about porosity, the osseointegration, elastic modulus, and coefficient of friction, which very easily, we know that porosity size matters. We started with plasma sprayed cups, and they have very little biological reaction. And whereas with the trabeculars, we move towards pore size that are bigger, and they have to be between 500 and 600 micrometers in order to enhance bone on growth. And for a proper integration of our components, we need both bone ingrowth and bone on growth. I worked in Sydney almost 10 years ago with Professor Walsh in his lab, and we used to do a lot of these studies, and we know that it takes between 6 to 12 weeks to start to see a proper bone on growth and ingrowth on the surface. This is actually a Ukrainian study with the University of Kiev and Professor Schwarzkopf. They compared plasma cups and 3D printed cups with an in vivo study, and this study shows actually no differences. So 3D printed are as good as more recent implants. When we talk about these components, we have to consider the elastic modulus that has to be close to the cancellous bone. And we have studies in literature that DEXA studies and CT studies that trabecular cups have stabilization of the bone marrow density around the cup, and they recover towards a normal value after the surgical procedure. The other element, very important, is the coefficient of friction. We need to have a coefficient that is between 0.9 and 1.2 in the 3D printed highly porous cup, and they do match this value, and is allowed to have a better initial scratch fit with these 3D printed highly porous components. Whereas with the form previously with other implants, it was very, very difficult to get to that point, and the stability was lower. We are all quite familiar with porous tantalum. Has a very long story. It's been around since the 90s. It's been considered the gold standard for highly porous metals for both primary and revision. It has 3 decades of clinical research and practice, and has proven osseointegration properties. But as we said, we moved towards a more elegant, sophisticated way to produce implants in order to achieve better integration between the host bone and the implant itself. So we need additive manufacturing. We have to create a controlled lattice geometry, which means that we have to create this 3D structure with a precise digital control. We have a very good elastic modulus that is close to the host bone, which means less stress shielding, and the continuous lattice helps to have a faster osseointegration. There's no coating interference. There is a higher durability, and enable surgeons and to have patient-specific and custom implants. and have very good results down the track. If we look at the literature, we can see that porous cups, 3D printed, have a better biological fixation and less fibrotic membrane formation at 1 year follow-up when compared to hydroxyapatite HA sprayed cups. Moreover, in this study with the tribe component, they made a comparison between 3D printed and conventional, and they shows that bone growth at 2 years is higher in the 3D printed versus conventional. Also, early radiological evaluation with more classification showed in these 60 consecutive cases better results and integration of the component up to 85% at 2 years follow-up. Regarding clinical evidence, we have very good results at short and mid-term, so up to 10 years. There's some studies show up to 100% survival rate, so no aseptic loosening. If we look at the registries show a comparison between 3D printed ultra-porous tantalum or titanium-coated cups, and there is actually no significant difference in terms of aseptic loosening and infection at 10 years follow-up. This is a very interesting case study from the New Zealand registry. They compared uncemented cups in general as a control and the 3D printed and uncemented implants. And it shows that controls do better than 3D printed. However, 3D printed cups were used more often for patients with a higher BMI and younger patients, which are generally more prone for revision. So this new technology that we're talking about uses laser beam with in an argon control atmosphere to turn titanium powder into this structure that is a random trabecular structure that mimics the structure of the host bone. They have a very high porosity. The surface is random and irregular, and the interconnectivity of the pore is up to 100%. The pore size is comparable to the one the literature suggests as the best one for bone integration. And the thickness of this surface, this rough surface, is between 1 and 2 millimeters, and it's very important to remember this when we do the surgical procedure. In vitro study shows comparable results with previous literature that I showed before, and very good osseointegration. And clinical results are very, very good. There's in this study of consecutive patients, there is no radiolucency at 4 years follow-up. So this is my clinical experience. I started in 2017 in a large hospital. We always use trabecular metal cups, and then when I moved to my practice, I started using more and more often 3D printed cups. I do both posterolateral and direct anterior approach. However, I'm moving towards full all direct anterior, and I'm starting to use more and more often 3D printed cups. And these are my complications. In the last 3 years, I didn't have any loosening of the cup yet. I want to show you some clinical cases. The first one is a 75-year-old female. She's been operated on the right hip in another facility. She came to me with a left hip pain, and I decided to proceed with a direct anterior approach. When I did the surgery, she had a vascular necrosis of the head, and I found out that she had quite significant bone loss, superior and posterior, like a Crow 1/2. So I decided to use a 3D printed porous rim-fit cup, tracer cup, and with a ceramic on poly. I like to use ceramic on poly, also if the polyethylene is vitamin E. And I use a short triple tapered double coated titanium hydroxyapatite stem. I did some impaction grafting and to fill up the gap, but I had a very nice primary stability straight away. I used 2 screws because I prefer to sleep better at night. Sorry for the quality of these images, but at 35 days down the track, I didn't see any resorption of the bone graft, and the cup is still there where I put it. This is a second case. It's a 61 years old lady. I operated on her a year and a half ago through a posterolateral approach. And with the posterolateral approach, I still use a Tracer 3D printed cup with a ceramic on plastic. This is a 50 cup on the right hand side with a 6 stem standard long stem and a 32 millimeters standard head. I replicate the same on the other side. I can show you briefly the surgical procedure, especially on the cup. I do medialize all the way down to the teardrop, and I then increase the size of my reamers. I want a nice bleeding bone. I always trial my cup because I want to see if I'm positioned in the proper way, if the cup doesn't stick out or is not lateralized. I check on the antiversion and inclination based upon bony landmarks and the transverse acetabular ligament. When I'm happy with that, I proceed with complete preparation of the acetabulum. If there's a little step, I take it off. We remember that we have 1 to 2 millimeters interference. I do rim line to line, but it's a very sticky cup. And then I don't want to have fractures of my acetabulum. So then I proceed with the positioning. I always double and triple check the orientation, and then I proceed with the impaction. And I always check if the antiversion and inclinations is optimal. Then I prepare with the progressive broaches. That's where I check the transverse acetabular ligament. I'm just slightly antiverted. I use a hooded liner with a posterior approach just because I prefer to use it. However, there's no clear evidence using flat or hooded. This is the stem that goes in. I impact the stem. I always take measurements before and after because I don't want to have leg length discrepancy. I'll proceed then with impaction and reduction of the of my hip, and I do all my testing with maximum degrees of internal rotation and flexion. I want them to be nice and stable. I used to have long time ago Harris caliper. This is a custom way to check the leg length. I can't check the offset, however. This is a third clinical case, a 51 years old lady with bilateral hip osteoarthritis. She's young. I want to preserve bones, so I go for a short stem and a 3D printed cup. She's doing very, very well, and she's going to have probably in the next 3 to 4 months other hip. This is another case, 81 years old gentleman. This is a direct anterior approach. The reaming procedure that I use is always the same. I only use a offset reamer for obvious reasons. It's easier to perform it. I always trial the cup because I want to be sure of the stability and inclination and antiversion, just to have an idea before proceeding with final cup. The stability is quite good. I always check that I don't have overhanging on the anterior aspect of the acetabulum to reduce impingement with the iliopsoas. This is the look of the cup. I then remove the trial cup. I always take x-rays intra-op. I always want to check if I'm deep enough and if I'm positioned well, if the inclination is good, if the antiversion is good. And then I proceed with the positioning of my definitive cup. And I always have a very nice feeling with these implants. They have a very high scratch fit. And when you put them down, they don't move anymore. This is a 36 millimeters flat liner. And then I complete my surgical procedure with the femur. So why choosing a 3D printed highly porous cup? Because they have excellent primary stability, both at the bottom and at the equator. They have proven biocompatibility and rapid osseointegration. It's a monolithic structure, so there's no coating, no delamination, no fatigue failure. They have very close modulus to host bone, which minimizes stress shielding and bone resorption. The high manufacturing precision and reproducibility gives you a standardized qualitative product and helps you also if you have to do more difficult cases like personalized surgery. You can do a CT scan. They can provide for you for PSI cutting jigs, and you can have for revisions modular stems for revision surgery. And also with the CT scan and PSI, you can have custom-made implants for very complex cases. Of course, there's limitations. The long-term data are still limited. There is evidence mostly midterm. We have good results, however, on the national registers, especially the Aussie one and the British. The prospective studies around, they have small study population, and the population is heterogeneous. However, the clinical results are quite promising. There is no clear superiority yet. However, the both in vitros and clinical studies showed very good results with when compared to high porosity titanium or tantalum cups. In conclusion, 3D printed highly porous titanium cups represent the latest technology that we have to improve biological fixation. They demonstrate excellent midterm results. They have comparable outcomes to other benchmark implants such as trabecular metals and porous coated titanium. They offer the advantage of early osseointegration and stability, and we need long-term data, especially from the registry, to confirm the durability and the good results that we're seeing today. Thank you very much.